the screen. Let's not wait the time. Okay. Good evening, everyone. Good evening. Okay, so as you can see on the screen today, again, we are talking about the anti-thrombotic agents, and there are a lot, right? So till now, we talked about the pathophysiology and the mechanism and the process of clot formation, right? And then in last class, we talked about the antiplatelet drugs, and today we are talking about thrombolytic drugs. Okay, thrombolytic drugs, as we have discussed, are to dissolve the clots, right? To dissolve the clots. So when we should give the thrombolytic drugs or thrombolytic therapy? Tell me, guys, when should we give the thrombolytic therapy? When it is warranted, when it is required to give the thrombolytic therapy? Tell me, guys. I'm not asking the indications. Please don't tell me the indications. MI, DVT, that I know. These are the indications. I'm asking when. What are the criteria to give thrombolytic agents? Yes, guys. What are the criteria? Okay, let me tell you. Let me ask you. Not let me tell you. Let me ask you one more question. Suppose one person got the no no thrombus formation. Definitely thrombus formation is the first criteria. Blood loss is the blood loss, not at all. No, we do not give any kind of bleeding risk. If any kind of bleeding risk is there, Shravani, we don't give thrombolytic agents at all. This is the major contraindication for thrombolytic agents we'll be talking about. So first of all, what we are talking about today is about the thrombolytic agents, types of thrombolytic agents, their doses, their mechanism of action, and the best part, what everyone should know is the contraindications of the thrombolytic agents. Okay, and along with that, criteria to give the thrombolytic agents. That is the importance of the thrombolytic agents. Okay, so when we should give the thrombolytic agents, let me describe. Okay, see, someone got the STEMI or the stroke, right? These are the major indications. Otherwise, there are another indications also. I'll be talking about those indications. But these are the topmost indications of or for thrombolytic drugs. Criteria, listen to the criteria. Within 4 hours of ischemic stroke, actually 4.5 hours. The study says the patient, if the intervention is not available, then within 4.5 hours, in case of acute ischemic stroke, we should give the thrombolytic agents within 4.5 hours. Okay, in case of transient attack, ITA, ischemic transient attack, ITA, this is also a stroke type, we can give within 9 hours. Okay, but the most benefit we get is if we give in the stroke patients within 4.5 hours. Okay, first 4.5 hours of the stroke appearance or the stroke onset. Okay, that is the criteria. Okay, in MI, within 2 hours, okay, within 2 hours of MI, we should give the guys, please mute your mics or I'll mute you. Okay, I don't want to mute you, but I have to because your mics are not off. I'm so sorry. Okay, now you're on mute. So sorry, but it's okay. Okay. So within 2 hours, we have to give the thrombolytic agents to dissolve the clot within 2 hours. Otherwise, what happens is the clot gets strong with the fibrin mesh mass. Okay, with the fibrin mass, clot gets stronger and stronger. Okay, and that will not help usually sometimes, and that could be dangerous, and that can grow like anything, that can grow faster and prevent the oxygen supply to the heart. Okay, that can stop the oxygen supply or partially or fully, and that will not be helpful. Okay, so usually in case of STEMI, within 2 hours we can give the thrombolytic agents. Okay, another conditions here are, if you don't have the availability of catheterization lab or interventional cardiologist or interventional lab, in those cases we give the thrombolytic agents. If the patient is suppose in remote, suppose the patient is in the village, somewhere deeper in the jungle, and that cannot reach to the hospital, to the cardiologist, interventional cardiologist, and some local doctor, if they are expert, again, if they are expert in analyzing and assessing the patient, remember that not to everyone and not everyone can give the drug, not everyone can give the thrombolytic agents. The patient should be assessed perfectly. On what basis? I'll tell you. Okay, thrombolytic agents or thrombolytic drugs are the most dangerous drugs and most helpful drugs also in case of heart attack, in case of stroke. So remember, that is why I'm taking the entire class on thrombolytic drugs. Okay, that's why I'm taking the entire class on thrombolytic drugs. Why? Because these should be carefully used, very carefully. We should know how to assess the patients for thrombolytic agents. What should be the what are the contraindications? What are the major and minor contraindications? What are the major indications? What are the major criteria to use the thrombolytic agent? That is the main agenda of today's class. Okay, if you know this, those and all are everywhere, you can find out. Okay, but these things you should know here, right? So first of all, in case of stroke, within 4.5 hours, the study says that if the streptokinase or ALTEPLASE or tenecteplase are given within 4.5 hour, the TPAs, the TPAs, can someone write the full form of TPAs? What is TPA? Okay, I'll write the TPA. TPA. Okay, TPA. This is the category of thrombolytic agents, thrombolytic drugs. Okay, so if we are giving within 4.5 hours in the stroke patients, that makes or that impacts a lot. The effect of the thrombolytic is most beneficial within 4.5 hours. And in STEMI patients or in acute MI patients, within 2 hours. Why I'm talking about STEMI patients? STEMI patients are, selected for the usually for the thrombolytic therapy, STEMI patients, because those are in more danger, and STEMI is acute coronary syndrome, and in such cases we should give them immediately. In such cases we should give them, yes, tissue plasminogen activators. TPA is tissue plasminogen activator, rightly said, rightly written here. Okay, so understand the criteria. First criteria is in STEMI 2 hours, in stroke within 4.5 hours, and if there is no availability of the intervention cardiologist, or if no availability of the catheterization laboratory. Okay, then the second thing here is, which is very important, that where we should not give the drugs. Okay, I'll come to that. So where we should not give the drugs, the contraindications. Okay, when we are selecting the patient, along with that, we should be very careful where we are not giving these drugs to the patients. Okay, we got the patient. If the patient is STEMI or a stroke within 4.5 hours, within 2 hours, if there is no availability of the interventional cardiologist or catheterization lab, we give that. Okay, selection of the drug is also important, but the contraindication, if there are two types of contraindication, guys, there are two types of contraindication where we should not give these drugs. Okay, first is absolute contraindications, means not at all, you cannot even give these drugs in such cases. Absolute contraindications means you should not give at all, otherwise you are making the patient die. Okay, you are putting the life of the patient in danger if you are giving the drugs in any prior intracranial hemorrhage, because these are absolutely contraindicated or contradicted in case of if the patient is having the intracranial hemorrhage or hemorrhagic stroke. Okay, any prior hemorrhagic stroke or intracranial hemorrhage. Then if the patient is having any kind of cancer neoplasm or intracranial malformation. Okay, and if the patient is having ischemic stroke also, if the patient got the MI or repeated ischemic stroke and the first episode of stroke is within 3 months, then absolutely no. Within 3 months, if the patient is having the history of ischemic stroke, I mean, see, ischemic stroke is the indication for ALTEPLASE, tenecteplase, or these urokinase, these DPAs, okay, or these thrombolytic agents. But if the patient is having the history of ischemic stroke within 3 months, we should not give it at all. Okay, if the patient is suspected dissection means nothing but any kind of infarction or cut or bleeding inside the any kind of vessel, usually aortic dissections. Okay, usually in aorta. Okay, if we find any dissection or if we suspect any kind of dissections, we should not give. Okay, we should not give in the patients with recent surgeries. We should not give in the recent head trauma patients or road accidental patients. We should not give in the patients who have bleeding diastasis. Okay, now why these all are absolutely contraindications, absolute contraindications? Because these all are increasing the risk of bleeding by 50 to 60% in such patients. Okay, that can lead to the death of the patient. Okay, so that's why we should not give absolutely no to such patients when we are choosing or when we are giving the thrombolytic therapy or TPAs. Understand? Now, relative contraindications. Relative contraindications means in vulnerable populations. Okay, if the person is more than 75 years of age, these are also on the urge of getting the high bleeding. Okay, maybe any kind of hemorrhage, any kind of maybe the gastrointestinal bleeding, right? So in the patients who are more than 75 years of the age, we should give under the strict monitoring, otherwise we should not give. Okay, we should give under the strict monitoring. Okay, then if the patient is on anticoagulants means heparin, warfarin, araxaparin, or maybe rivaroxaban or anything, any kind of anticoagulants, we should not give. Okay, because that is definitely contradicting to each other. Okay, then if the patient is pregnant or the female, I mean usually here the female pregnants, okay, female patients who are pregnant, we should not give in such cases because that can affect the fetus, that can lead to the abortion or premature abortion. Okay, and then the patients who undergone the resuscitation or CPR before 10 minutes. Okay, at least more than 10 minutes CPR given for more than 10 minutes. In such cases also we should not give because there are also very what we say the viable to get the bleedings or get some hypotension also, because these are also leading to the hypotension. Okay, and then recent internal bleeding. So definitely in bleeding cases we should not give. Uncontrolled hypertension also we should not give, because it can lead to the multiple organ failure. Okay, it can lead to the hemorrhage. Okay, it can lead to the hemorrhage. Remote ischemic stroke also we should not give. Remote ischemic stroke means not at or not in the carotid artery, but somewhere else, some peripheral carotid arteries, or maybe the basal carotid arteries. In such cases also we should not give the thrombolytic agents. And then if the major surgery has happened within 3 weeks, okay, recent surgery, so definitely absolutely contradicted. But if it is within 3 weeks, then we should also restrict or give under the strict monitoring, or the patient is young and have no other problems, then in the strict monitoring, or we should not give actually. Okay, so these all are the contraindications we should keep in the hand when we are selecting the patient. So we should ask them all these things along with those indications, along with those criterias. We should ask the patients all these, and if you are suspecting any of these, just immediately remove the plan. Immediately, just don't give the thrombolytic agents, because it can lead, or it can risk to the death, or it can risk to the major mishappenings with the patients. Okay, so that is the major criteria what we should keep in mind when we are talking about thrombolytic agents, or when we are giving, or when we are thinking to give these thrombolytic agents to the patients. Okay guys, now let's come back. So what are the thrombolytic agents and how these work, that is also important. So thrombolytic means simple. When we are talking about thrombolysis, means dissolving the clots. Okay, so lysis means breaking, lytic. Okay, so these are nothing but doing thrombolysis. And lysis, everyone knows, lysis means breakdown. Okay, lysis means breakdown. Lysis means breakdown. So these are breaking down the plaque or clot. Now let's understand how these agents, how these agents, TPAs or thrombolytic agents, are breaking the clot. Okay, how these are breaking the clots. So let's go back to our yesterday's or day before yesterday's class. This is the vessel, this is the injury, right? Platelets, other masses, lot of things are there. This is the clot, this is the clot. So these are the platelets, and other factors. And now this is the fibrin, this is the fibrin. Okay, this is the fibrin which is making the clot strong, now what happens is, when we give the thrombolytic agents within 4.5 hours in case of a stroke, and within 2 hours in case of STEMI, what happens is, these go to the site. And guys, importantly, plasminogen is one of the another factor which is already there in your blood. Plasminogen is also like plasminogen is also already there, like the prothrombin as prothrombin, and fibrinogen which turns into fibrin. So these all inactivated form of these elements are already, or these factors are already available in your circulation system, in your circulatory system, in your blood. So similarly, plasminogen is also available, in your circulatory system. So what these drugs do is, see, these drugs come to the site and they catch the plasminogen, and they activate the plasminogen into plasmin. Okay, so that's why we call them tissue plasminogen activator. So plasminogen is coming into circulatory system by two. One is already available in the circulatory system, and one is coming from the injured site. This is also coming from the injured site. Okay, secreting from the injured site, and these factors are coming and activating plasminogen into plasmin. Okay, so what exactly is plasminogen? Again, let me tell you in simple way. Plasminogen is one of the attachment of fibrin. You know what is fibrin? Sorry, I'll let me erase it and tell you. Okay. Okay, so what is exactly the fibrin? Plasminogen. So fibrin, what is fibrin? Fibrin is nothing but this blue mass which is making the clot strong. So fibrin, when we take as the component, fibrin also has the attached plasminogen. Okay, attached plasminogen. So what this does, what this TPA does is, usually whatever is available in the circulatory system or secreted by the injured site or attached to the fibrin. Remember these three things, three parameters. These convert this plasminogen into plasmin. Okay, and it breaks the fibrin. It breaks the fibrin, and the breakage of fibrin is called fibrinolysis, right? When it breaks the fibrin, when it is breaking the mass, that means the remaining elements will again start floating, in the circulatory system. Okay, and these things will cut down the fibrin mass. Okay, this mechanism will cut down or break down the fibrin mass and dissolve the clot. This is a simple mechanism. Okay, this is a very simple mechanism to understand. See, this is plasminogen activators here. Okay, plasminogen activators here, right? Urokinase, streptokinase, and all, right? These are activating the plasminogen into plasmin. Okay, and this plasmin is detaching from the fibrin, and this is also breaking down the fibrin. As you can see the seizure here, this is doing the fibrinolysis and making the fibrin degradation products. Degradation products means when fibrin is breaking down, then this mass will break down and other elements will break down. Fibrin will break down into fibrin degradation products like plasmin and other things, and this is the breaking or breakdown of this mass or the clot, right? That's how this is, these that's how these fibrinolytics or what we say, this thrombolytics work. Okay, that's how the thrombolytic agents work on the clot or on the plaque. Okay, so this is the major mechanism, right? And there's the major criteria and contraindications. Now, indications of thrombolytic agents. If I talk about thrombolytic agents, okay, so I just talked about three things. Okay, two things actually. One is stroke, right? Ischemic stroke. Okay, second is MI, right? Third is transient ischemic attack. Also within 9 hours we can give transient ischemic attack, that is also stroke. Now the other important utilizations or uses or the indications for thrombolytic therapy are PE, pulmonary embolism. Okay, pulmonary embolism, and the criteria is almost same. Okay, but pulmonary embolism criteria is quite early, within 40 minutes. Okay, usually if the patient is in the hospital, then only you can give the plasminogen activators. Okay, tissue plasminogen activators in case of PE, pulmonary embolism, within 40 minutes is the most beneficial. Within 40 minutes is the most beneficial in case of thrombolytic agents in pulmonary embolism. Okay, then the DVTs. Okay, in case of DVT also it should be given within 4 to 9 hours. Okay, and then along with DVTs, PAD, pulmonary arterial disease, right? Either in your upper limbs, your arms, your legs. Okay, wherever you get, usually in the PADs also the thrombolytic therapy is recommended. Okay, in the PADs also the thrombolytic therapies is recommended according to as per the MI criteria. Within 2 hours to 4 hours we can give in the PAD. Okay, and along with these six, the very important indication is again the transcatheter occlusion. Okay, transcatheter occlusion. What is transcatheter occlusion? As I told you, if the kidney graft is there and for the hemodialysis, then sometimes these occlusions are there in the catheter. Okay, so transcatheter occlusions are also can be opened with the thrombolytic therapy, but again we have to follow the MI criteria. Okay, so these are the major seven indications for what? For the thrombolytic agents. Okay, for the thrombolytic agents or thrombolytic therapy, major seven indications. Okay, guys, and you note it down the contraindications. Now let me tell you what are the drugs. Okay, thrombolytic drugs or thrombolytic therapy. So what are the thrombolytic drugs? Okay, majorly we have divided the thrombolytic drugs into two categories. Okay, now let's come back. We'll see here only, and then I'll go to the classification. There are two types of thrombolytic agents. One is fibrin specific, one is non-fibrin specific. Okay, fibrin specific, non-fibrin specific. So let's go and check. Okay, see, one is fibrin specific, one is non-fibrin specific. So what is fibrin specific? Let me tell you. Okay, so let's discuss non-fibrin specific first. Okay, non-fibrin specific first. Okay, so non-fibrin specific will work on, remember guys, this is very interesting, fibrinolysis. Okay, there is term fibrinolysis. Non-fibrin specific work on fibrinolysis and fibrinogenesis. Okay, fibrinolysis and fibrinogenesis. So what is fibrinolysis? Non-fibrin specific drugs helps in dissolving the fibrin mass. Okay, helps in dissolving or breaking down the fibrin. Okay, and along with that, non-fibric agents, non-fibrin specific agents also helps in stopping the fibrin manufacturing, I will say in the simplest, in the layman term, in the conversion of fibrinogen into fibrin. Okay, so let's talk where they usually work. Okay, so if I'm talking about non-fibrin agents usually just break the fibrin into fibrin components. Okay, fibrin dissolvents. Okay, and these are also stopping what? These are also stopping fibrinogen conversion to fibrin. Okay, these are also stopping this process. These drugs, non-fibrin specific drugs, are also stopping this process. So these are blocking the entire system by two mechanisms. One is blocking the formation of fibrin and even dissolving the fibrin, breaking down the fibrin. This is the work of non-fibrin specific thrombolytic agents. And if we are talking about fibrin specific fibrin specific agents are only breaking down the fibrin, but when they kept in the exposure to with the fibrinogen, with the fibrinogen, they don't help stopping the conversion of fibrinogen into fibrin. Okay, so understand, so they are just working with the first mechanism, but not with the second mechanism. So important are non-fibrin specific. Okay, important drugs are non-fibrin specific, and fibrin specific are very kind of not that important, not that what we say effectiveness is almost similar of both, but these fibrin specifics are working only on one process, but non-fibrin specifics are working on both the systems, both the processes. Even the making of fibrin will be stopped, will be broken, and the fibrin also will break down with the help of these. So fibrin specific tissue plasminogen actors, activators, TPAs are alteplase, retiplase, and tenecteplase. Okay, we can remember these by art. So when we are talking about fibrin specific, you can remember fibrin specific art. Okay, A for ALTEPLASE, R for retiplase, T for tenecteplase. Okay, fibrin specifics are ART. Okay, here they have written. Remember with the ART. And non-fibrin specific are streptokinase and anistreptase and urokinase. So you can understand by the country name or country's abbreviation USA, United States of America. So U stands for urokinase, S stands for streptokinase, A stands for anistreptase. Okay, anistreptase, right? So you can understand non-fibrin by USA and fibrin specific by ART. So there is common A, there is common O, A. So in non-fibrin specific, you should not, remember it by ALTEPLASE, but that is anistreptase. Okay, remember that. So these are two types of thrombolytic drugs. One is non-fibrin, one is fibrin. Understand? Okay, guys. So remember, these are things. So as I told you, these work non-fibrin specific are working with two mechanisms. First of all, is breaking down the fibrin by activating the plasminogen into plasmin, right? So this is the first process. This is the first process, breaking down the fibrin into fibrin split products. And second is stopping the fibrinogen into conversion of fibrin, right? So they are breaking down the fibrinogen also and not helping it to convert into fibrin. So they are also producing the degradation product of fibrinogen, okay, because it is not converting into fibrin. So these are blocking the effect, blocking the process by two ways: non-specific, non-fibrin specific. Okay, fibrin specific are working only on one process. I hope you understand that, guys. Okay, so you can understand by ART and USA. Drugs are here. See that these are the drugs. Okay, these are the drugs, common drugs. First of all, as I told, ALTEPLASE, retiplase, and tenecteplase. These three are. Let's understand one by one. ART, retiplase, and tenecteplase. Okay, these three are the fibrin specific drugs. Fibrin specific drugs, and in these, remember, these indications are FDA approved. See, these are indicated for many things like pulmonary embolism, DVT, STEMI, and all. But specifically, the according to the trials, according to the benefit risk ratio, what exactly they are approved for. So this question is very important. If I'm talking about, this, what? ALTEPLASE. ALTEPLASE is FDA approved for acute ischemic stroke. Okay, this is also FDA approved for acute pulmonary embolism. This is also FDA approved for MI. So that's why TPA, this tenecteplase, ALTEPLASE, this is very, very good and it can be useful for multiple purposes. Okay, ALTEPLASE could be useful for multiple purposes like stroke, acute MI, and acute pulmonary embolism, right? So in case of acute ischemic stroke, first we should give 0.1 mg per kg bolus, then 0.8 mg per kg infusion over 60 minutes. Okay, this is for first 60 minutes, this is for next 60 minutes, or that is the major dose which is approved by FDA. In acute pulmonary embolism, 100 mg of ALTEPLASE over 2 hours infusion. Okay, for STEMI, like more than 60 kg, it can be given 100 mg in total. With this, like first 2 minutes 15 mg bolus, and then 30 minutes 50 mg, and then 60 minutes 35 mg. Okay, if the patient is less than 67 kg, then 100 mg maximum we can give. So 15 mg first 1 to 2 minutes, 15 mg. Okay, and then 0.75 mg per kg for 30 minutes, and then 0.5 kg per mg per kg for 60 minutes. So if the patient is more than 67 kg, the dose is fixed, like 15 mg for first 2 minutes, then 50 mg for 30 minutes, and then 35 mg for 60 minutes, right? So 100 mg. Okay, and then if it is less than, then you have to be calculative. Okay, you have to be very calculative. The patient is lean, if the patient's weight is not more than 67 kg, then you have to be very careful about the calculations of the dose, because first 2 minutes you can give the 15 mg bolus. Okay, but after 2 minutes you have to be very calculative, like 0.75 mg per kg over 30 minutes, and then after 30 minutes for the 60 minutes 0.5 mg per kg. Okay, so these are the given things. Okay, and If I talk about Retiplase, it is FDA approved only for STEMI, not for the stroke or pulmonary embolism. It can be given 10 units IV over 2 hours and repeat in 30 minutes, right? And then streptokinase is approved for all DVT, PE, and STEMI, not stroke. Okay, remember, streptokinase is not for stroke. Remember, it is not approved FDA for stroke. So, and yeah, usually it is given IV, but they have the fixed dose. Streptokinase is the fixed dose, 1.5 or 2.5 or 10 million, international units that can be given over 30 minutes to 60 minutes. Okay, and in case of PE, we can give it the 1 million units, 1 million units, and 1 million units per hour for 24 hours in case of PE, right? So this you can study by yourself. This picture is there already, available in Google also. So these are the doses, okay, like for Alteplase, Rectiplase. But most important things to remember is Alteplase is used in stroke, PE, STEMI, but not in DVT. Retiplase is only FDA approved for STEMI. Streptokinase is FDA approved for STEMI, acute pulmonary embolism, and DVT, but not stroke. Tenecteplase is also approved only for STEMI, and urokinase especially is approved only for the pulmonary embolism. Urokinase is only approved for the pulmonary embolism. Okay, and there are other drugs which are also for pulmonary, Alteplase and streptokinase also, right? So we can say all the fibrin non-specific drugs or non-fibrin specific drugs can be used in pulmonary embolism also. Okay, right, guys? So that's I think all about today's class. And if you have any questions, we can answer. Okay, so not so long but important. Yes, guys, please tell me any questions if you have. Any questions do you have, guys, here? Yes, very important question. I forgot very important question here. Okay, I have to talk about, because I did not keep that slide here. Tell me. That's we forgot. That we forgot. Side effects of thrombolytic therapy. Anistriptase is not used in India right now. Okay, but the dose and all, anistriptase, as I told, is fibrin non-specific. It is fibrin non-specific, and this is not FDA approved yet for anything, but under the trials it is, and it can be given for STEMI and stroke. Okay, STEMI and stroke, and they are finding out some more. I mean, there are the trials, but it is not FDA approved yet because they did not have the very strong evidences for anistriptase. Okay, bleeding PR, bleeding, uncontrolled bleeding, hemorrhage, gastritis. Okay, can you tell again about fibrin specific? Okay, definitely I'll tell. Hypotension. Okay, so side effects I already told you. First thing is bleeding. Okay, major side effect is bleeding. Okay, so bleeding could be from gums, GI bleed. GI bleed is major. Okay, GI bleed is major, right? And gums bleeding. And what else? Hemoptysis. Okay, hemoptysis. Can someone tell me hemoptysis? What is hemoptysis? Then nasal bleeding. Okay, then hemorrhage. Hemorrhage. Okay, so these are the types of usual bleeding what can appear in case of the thrombolytic therapies. Okay, thrombolytic therapies, these type of bleedings can occur. Bleeding with cough. Okay, blood with cough or bleeding in sputum is known as hemoptysis. Yes, okay, correct. So that is hemoptysis. Okay, so these are the major bleeding sites. When I'm talking about GI bleeding, that could be major, and then gum hemoptysis, nasal bleeding, or hemorrhage. Okay, so that can happen in the patients as a side effect of thrombolytic therapies. And along with that, usually the patients get nausea, vomiting, or we say the gastritis effects. Okay, gastrointestinal effect, GI effects. Okay, GI effects are major, but not as the bleeding. And then intracranial hemorrhage. 3 is intracranial hemorrhage. Okay, hemorrhage can be there with these things. Okay, they are with as a side effect of thrombolytic therapies. And now someone was asking fibrin specific and non-fibrin specific. So let me tell you what is fibrin specific and what is non-fibrin specific. So fibrin specific. Okay, so fibrin specific drugs are only working in breaking down the fibrin. Okay, that process is called as fibrinolysis. Only they are breaking down the fibrin into fibrin, what we say, fibrin supplements or fibrin, whatever. I mean, only fibrin they are breaking down. Only they are breaking down the fibrin. Only fibrinolysis. But if I'm talking about non-fibrin specific, their scope is quite wide. These are not only working with fibrinolysis, means they are not only working in the breakdown of fibrin, but they are also stopping stopping the formation of fibrin. Okay, formation of fibrin. And what is formation of fibrin? What is formation of fibrin? Like conversion of what? Conversion of conversion of what, guys, tell me? Fibrinogen into fibrin. Okay, so this is stopping also the conversion of fibrinogen into fibrin. So fibrin is, they are stopping the generation of fibrin, and also they are breaking down the fibrin. So non-specifics have the wide role and wide responsibilities in the stoppage of clot dissolution. Okay, we are dissolving the clot here. These are helpful in dissolving the clot, right? And even making the clot. So it will help in not making the new clots, right? Understand? So non-specific means have the wide scope in the fibrinolysis and fibrinogenolysis. Okay, and fibrin specific means only working on the fibrin, not the fibrinogen. Okay, why these are not specific? Because these are working on fibrinogen also and fibrin also. Why fibrin specific? Because these are only working on fibrin, not fibrinogen. Okay, that is the major difference. Okay, yes guys, any other questions? Any other questions, guys? I'll be seeing you the next week. Not on Tuesday for sure, because I'm traveling, but very soon. Okay. So take care and have a good night. If no questions, I'll see you in the next class, guys. Thank you. Take care, guys. Take care. Have a good dinner. Have a good dinner. Good night. Thank you.